Hello, welcome everybody, and I'm going to start our session. Apologies for a short delay. Welcome, and just letting you know that I'm Janine Bush. I'm the new CEO of the National Centre for Action on Child Sexual Abuse, and I want to thank you so much for joining our In Conversation webinar today. The National Centre has been running these webinars for some time, and I'm really looking forward to our conversation with the panellists joining us to discuss aged care for survivors of child sexual abuse. Before I introduce our panellists and say more about the session, I firstly want to acknowledge that we're on Aboriginal land, and I want to pay my respects to all First Nations people and Elders past and present. I'm joining you all from the lands of the Wurundjeri people of the Kulin Nation. And I'd also like to pay special homage to survivors of child sexual abuse and acknowledge the lifelong impact of abuse. And reflecting on the lifelong impact of child sexual abuse is timely given the topic of our subject today and our discussion on aged care for victims and survivors of child sexual abuse. Before I continue on, as with all of these events, I have some quick housekeeping and general information to run you through. So just letting you know that the session is going to be recorded and it'll be sent to all registered participants. And we'll make this publicly available on our website within 2 weeks. We also encourage during the session for you to post any questions in the Q&A function, and the team will help me to get through as many of the questions we possibly can. And if we can't get to all of those questions, we'll try to provide responses out of session, either written or recorded. Additionally, letting you know that relevant handouts will be, and resources that we refer to today can be found in the materials section in the webinar, which is on the top right, I understand. And any additional materials that we mention will be provided after the session. Also, everyone will get an email after today's session with an evaluation link. And just wanting to let you know that it really helps us to improve future sessions and other information that we provide. So if you can take the time to provide some feedback through the survey, that will be greatly appreciated. Now, I also want to let you know that this In Conversation webinar and the work that the National Centre does often discusses sensitive information relating to the experiences and impacts of child sexual abuse. So many of you will be familiar with the relevant support services, but to assist with anyone who feels a need to reach out either during or after this session, we've included some information about those support services. So I'll move on to a really brief introduction about our subject for today, which is on aged care for survivors of child sexual abuse. And I just wanted to say that I'm really mindful that the topic of residential aged care for survivors of child sexual abuse, or of survivors of child abuse more generally as well, has been quite topical at the moment, which is probably a really important thing. We know that many older adults live with the impacts of child sexual abuse, and that many have never disclosed and may never want to, or may never feel the need to disclose their experience. And throughout this webinar, we'll be referring to this as non-disclosure. Again, obviously we all get older, and this often comes with critical transition points of engaging with aged care and primary healthcare services when we have different health and wellbeing needs as we age. And the needs of people who've been exposed to institutional settings are sometimes something really critical for us to consider in aged care context, particularly residential care. So to discuss these issues today, we are very fortunate to have a range of experts who bring lived experience, research insights, cultural wisdom, and also practice expertise. Understanding the diverse needs of people who access the aged care system includes having insights into the significant impacts of child sexual abuse and experiences of institutional care through a person's life course. as older adults require their requirements for healthcare change. So I'm really looking forward to hearing the views of everybody we've got here today. And I just also wanted to make a mention that we've referred to compassionate care, and I'm very mindful that that is a contested term, and we'll be talking a little bit more about that. And I'm sure that all of you, if there's any practitioners here today, that you'll learn much from our panel members today. So let me just briefly introduce you to our participants today. And I'll also let you know that we have their biographies in the materials section of the webinar that you can refer to. So firstly, I'll just let you know that we have Dr. Frank Golding with us, and Frank spent his childhood as a state ward in foster care and of orphanages where abuse was common, and he's since become a teacher, researcher, historian, advocate and writer, and holds a lifelong membership of Care Leavers Association network, also known as CLAN. Frank has an interest in how we can carry our history with us and give voice to insider knowledge to disrupt and challenge dominant narratives. We've also got Leonie Williamson with us, who's a descendant of the Gubbi Gubbi and Butchulla peoples through her father and has maternal roots in northwest Queensland. And Leonie is the Deputy CEO of the Healing Foundation, with over 20 years of experience in Indigenous policy and programs. Sarah Morris is with us today as well, and she's a social worker and early career researcher, currently working as a research fellow with Monash University. And Sarah has lived experience of out-of-home care and is passionate about applying her insights into academic research. We also have Darcy Orr with us, who's the cluster lead of Lotus Support Services, with the not-for-profit organisation Micah Projects. And Darcy's worked with the community services sector for over 13 years and has been inspired by the advocacy of forgotten Australians since starting with Lotus Place. So welcome to everybody, and thank you so much for joining us. So to start our discussion today, I'm going to move to the complexities of disclosure and non-disclosure. And as I've explained, we're talking today about the needs of older people with lived and living experience of child sexual abuse as they start to engage with aged care services, both in home and residential care. We're hoping to focus on how aged care providers can ensure older people get the health and wellbeing care that they need, regardless of their experiences, while also identifying what practitioners need to be conscious of when they're engaging with people who have had lived experience of child sexual abuse. Look, it's a well-known fact that not everybody discloses their experience of child sexual abuse. The Royal Commission into Institutional Responses to Child Sexual Abuse identified that for those who do disclose, it can take on average around 24 years for a person to tell anybody. And even when people do disclose, we know that there are complexities surrounding disclosure and that it's not a one-time event. Every new person we meet will know nothing about us, and people will make decisions about whether they do or don't disclose in different circumstances. Leonie, perhaps I could get your thoughts on this and give us particularly any considerations you might be able to share with us about First Nation survivors.
Thank you, Janine, and thank you for that introduction. I'll also add my acknowledgements to the traditional owners of the lands from which I join, the Ngunnawal and Ngambri people, also to stolen generation survivors and descendants whose work and stories we carry a lot of knowledge through for our work. Also to the survivors more generally of child sexual abuse and the wisdom and the knowledge they do, both those who have disclosed and also those who haven't yet found the words to do that. So just into some of that context that you provided, Janine, I'd like to provide some of my own. So the work that we do with stolen generation survivors, and thank you, to the National Centre for organising this, very important topic around access, to aged care for survivors of child sexual abuse. What an important context when working with Aboriginal and Torres Strait Islander people and stolen generation survivors within that is that up until the late 70s, 1 in 3 Aboriginal children were forcibly removed from their families under past government policies. So many were placed in institutions where childhood sexual abuse was quite common. It was understood to be quite systematic. Some of what the Royal Commission reported from that was that around 62% of survivors that they interviewed through the Commission were abused in these historical settings, such as residential institutional settings, missions, reserves, and also that from our own evidence and research into experiences of survivors of the stolen generation, that 36% of survivors reported experienced child sexual abuse. We expect that some of those statistics are probably under a representation of what really occurred. So we know that stolen generation survivors, a lot of Aboriginal and Torres Strait Islander, who will make up a large proportion of Aboriginal and Torres Strait Islander people who are currently eligible and accessing child aged care services, were likely to have experienced not just child sexual abuse, but also physical and emotional and cultural removal. So there's a whole sort of like parameter that goes along. So yes, disclosure is important, but I think that broader context of Aboriginal and Torres Strait Islander history and the history of stolen generation survivors is also key for practitioners and policy makers to understand when working with Aboriginal and Torres Strait Islander people, and the likelihood of these types of abuses have occurring, and to be evident in systematic behaviours, resistance, removals, but also some of those trauma symptoms. So how that shapes how survivors and descendants experience aged care today and other institutions. I think there's that lack of cultural safety and fear of racism, mistrust of systems, the sense of shame about protecting self, their family, their communities from the stigma. But also silence was such a huge part of survival for many children in institutions and in care, that that behaviour can often stay with you for a long time. And also a lot of the time people have disclosed. They've disclosed and it's not been believed, or it's not been recorded, the right responses haven't occurred to it. So I think when we're dealing with issues of non-disclosure, there's probably a few factors that come into that. Yeah.
Great. Thanks so much, Leonie. They're really important reflections for us all to bear in mind. Frankly, we're talking about disclosure and non-disclosure in the context of aged care settings.
I think I'd like to echo a lot of what Leonie said in terms of like shame, stigma, and the fear of disbelief. Many older care leavers that I've interviewed throughout the Healthy Aging study, some of them do not want to even talk about that part of their life. They've moved on and they've created a new life since. So I think a lot of it comes down to the individual and their inherent needs, and we need to respect that, because the horrors that some of the older care leavers have shared with me, which I feel very fortunate to hear their stories, I don't think anyone would want to relive that. And each time you enter a service, having to delve back into that part of your life and relive that trauma through speaking through it and disclosing is often too much for a lot of people. So I think we need to respect and honour people's experiences and how they wish to deal with them, because disclosing is a personal choice and it really needs to be respected and honoured, and it will differ with each individual. Yeah.
Great, thanks, Sarah. And Darcy, also interested in your reflections on this issue around disclosure and non-disclosure, and obviously reflecting on the reality that a lot of people don't disclose and don't necessarily want to, and that can change and vary depending on the circumstances.
Yeah, thanks, Janine. And look, I agree with what Leonie was saying, and also Sarah. Look, I think rather than getting into the reasons why somebody may or may not decide, that can be an intensely personal decision, and there's a range of reasons that go into that thought process. But just in terms of a structural position, I suppose, I mean, I would say you mentioned before, Janine, around the on average 24 years it takes for somebody to disclose a history of sexual abuse, and I don't challenge that at all. But what I think is an even more accurate statement is the Royal Commission provided the first opportunity for many people participating to actually be believed for the first time. So I think it's important that we make the point that there are likely many people that in one form or another had attempted some form of disclosure, whatever that may have looked like in their childhood when they were at their most vulnerable stage, but they were not believed. And that is something that has been, a terrible issue across the country for many, many years. So when you're considering participating in some type of justice-making process, for example, the idea of disclosing, I think many people say to us as a service, I'm not going to be believed, I wasn't believed. People knew about it, it still happened, so what's the point? I think there are some contemporary things going on at the moment. So we've got the DP versus Bird High Court decision recently. I'm not a solicitor, but I think this was a technical decision made by the High Court where it was found that a Catholic priest was acting in a spiritual vocation and was not actually formally an employee of the Catholic institution, and therefore it waived the right for the victim to pursue any sort of litigation. So that's got really far-reaching consequences. I imagine as a victim of institutional sexual abuse or childhood sexual abuse, that is going to be a pretty distressing outcome to hear. So, you've got to balance it up. Is it worth going through that process when there's no guarantee that you're going to get a positive outcome? I think that weighs incredibly heavily on many people's minds. I think that many institutions are potentially quite litigious as well. And so for somebody to disclose, it may be something that they've heard from family members, from friends, from reading from media to know that there is likely a big fight. And I think people weigh that up to consider, is it worth going through that process? And a lot of the people that were historically abused, I think, are the survivors. And there are many, many people that can't participate in this conversation because of the impact of that abuse, the comorbidity, the impacts of health outcomes, the suicide that has taken place all across the country. So a lot of these things, I think, factor into a decision for somebody to make a disclosure or not. And just a really brief sort of thought experiment for people. If we're talking about in an institutional setting, the reality is that there are many people that were abused in a faith-based or a state-run institution, for example, as a child that are now finding themselves in a faith-based or a state-run institution at their most vulnerable, again, at the other end of their life. So the prospect of disclosing abuse to the same institution that was responsible for harming you must be an incredibly terrifying prospect, and there's no guarantee of a positive outcome. So I think really what we need to reflect on is the structural responsibility that we all have as service providers and stakeholders and government and all of us to facilitate a process that people feel like they're going to be believed, feel like they're going to be respected, and create space for people to make an informed decision about disclosure. And we've got a long way to go before I think people feel comfortable in that area.
Great. Look, thanks for those points, Darcy. That's they're really important. And Frank, coming back to you, one of the question that I put was really keen to hear about your thoughts and experience on disclosure in the context of service provision in aged care settings and the relevance of trauma-informed care. So over to you, and I know you can't see us, so...
Yes, sure. Thank you, Janine. And I agree with all of the above, what I've heard of it. I would perhaps want to place less emphasis on the deep shame and humiliation experienced by victims, especially in closed institutions like orphanages. And not to deny that's not deeply felt, but I'd prefer to point to how past disclosures were handled. And I'm in Ballarat today, and I was in the Ballarat orphanage, and my own orphanage. The power imbalance was so strong, and the betrayal of trust was so evident. Children were actually disclosing to the police their sexual abuse by the superintendent of the time. But the superintendent and the chairman of the board of managers of the orphanage actually intimidated and punished the children for complaining. One girl was shifted out of the orphanage to a reformatory in Melbourne because she was a complainant and strongly refused to back down. And I think the word gets out from people. If you complain, you'll be punished. You'll be worse off than you are. You better be kept quiet. Now, given all that, I think it's fair enough to say that a lot of children who grew up in institutions, childhood institutions like the Ballarat Orphanage, actually have a total mistrust of the system. That particular perpetrator was brought to trial, but at the second stage of his trial, his solicitors pleaded the old age and frailty, so the trial won't proceed. And that's a further blow to people who say, well, you know, you can't trust the system. They're all part of the system, and they go then on to say, well, why would I trust the aged care system any more than I trusted my childhood institution? It's a very deeply felt and widely held view. That's all I wanted to say at this stage.
No, look, thanks so much. I think it's really important to think about how that lack of trust that you've all made reference to has implications for people as they get older accessing aged care services, and particularly those that might be residential, but also having people come into your home to provide services when you have a deep mistrust of the service system. Look, we also thought that it would be good to chat a little bit about language, and I raised this at the outset around the controversial nature of the term compassionate care, but we do know how powerful words can be and how labels get attached to people and can follow them through their lifespan. So just look, I'd go over to you, Darcy, just wondering what your thoughts are on terms like compassionate care, and what ways do you think that we can use terminology effectively to ensure that older survivors of child sexual abuse can get the care they need in the context of healthcare service provision?
Thanks, Janine. Look, I think that, language, as we would all agree, is incredibly important. The identification of a term like compassionate aged care, I think, comes from a really good place. But, I would say I don't know, based on what Forgotten Australians speak to me about, I'm not sure that survivors need compassionate aged care. I think of the definition of compassion being about sympathy and concerns around the misfortune of others. I think that there is a deep frustration that many with a history of sexual abuse have around buzz terms, around language, which can make a lot of sense when we're sitting around as a service provider, for example, and talking about a framework, but what meaningful difference does that create in the lives of victims? I think that's the disconnect. I think for victims to feel respected for who they are, I think that's incredibly important. And the identification of the abuse of power that occurred in previous care is essential for providers to understand. They need to know that that there is care and they have choice about carers that they might not feel uncomfortable with, and that their views won't be minimised or dismissed. Carers need to be trained in understanding how unfinished business, such as the pursuit of justice, can have an impact on how people communicate, and feelings of loss and grief and feeling of being alone. And there are some really fundamental principles that the people that we talk about really ask for when it comes to service delivery. I don't think often people say to me, I want a trauma-informed framework when I'm accessing service, because the reality is trauma-informed care can mean different things depending on what system you're interacting with. I think people often talk about being removed or restricted from services that say that they are trauma-informed, but by having a trauma response, they're often excluded from services. So as somebody trying to navigate through these systems, I think what people are really seeking are just some really fundamental principles to engaging, and that's things like having service providers be trustworthy, opportunity for things like peer support, making sure that the individual has total ownership and agency over the process that they're interacting with, and recognising trauma responses. Like, it's not rocket science, I think, what people are asking for. And so while a lot of terms are well-intentioned, often the momentum behind that intention stops because we get a good sort of term. And I think that people are frustrated with language that doesn't go anywhere.
Great, thanks, Darcy. Do any of the other panel members have any comments that they'd like to make in relation to language? Sarah?
If I could.
Oh, sorry, Frank, you go. You can,
Frank?
yeah.
Yeah,
And then Sarah.
I'd support everything Darcy said. I think people are over those buzzwords like compassionate care and trauma-informed treatment and so on. They actually want to see it practiced. So they want to see evidence that people practice respect and they support people's dignity and they show kindness rather than just the words themselves. So it's action. And if we could have more examples of people actually showing that compassion rather than using it in a charter or in the brochures that go out and so on, that would do so much more good.
Just wanted to comment on
Yeah.
in terms of how the systems have used language as a form of control and coercion. So if you look at the power of language and how that's often been used against people, whether you look at their court reports, their documentation or lack of documentation, or stripping the autonomy, the rights and the choices of children and young people. So I think there's a deep-seated mistrust of systems and language because of that, because I know personally throughout my life when I was in care, language was used against me time and time again. What was written in my reports was not matching with what was my experience. And I think that's the key component of this. It's language has been used against us, and what we want to see is action. So we don't care what kind of little bow you put on what word you're using, it's how you actually operate in practice and how you actually uphold the dignity, rights, autonomy, and just human rights of each individual and respecting that.
Yeah, thanks, Sarah. That's a consistent theme coming through there about the importance of action rather than words and the mistrust of words. Leonie, did you have some further comments as well?
Yeah, sorry if I could jump in, and I'll probably play a little bit of a divergent view on this, but and I think that we need to be clear is that what are we talking about? Are we talking about the language or the concepts or the theory or the failure to translate those into implementation and practice and systems change? Like, I think that's that's a failure. But I think the concepts and the theories and the understandings underpinning them are very important, and I think this is a really big thing because, for Aboriginal and Torres Strait Islander people, for stolen generations, survivors, we have long advocated for trauma-informed approaches, and also cultural safety is another one that I think is actually often lumbered into, oh, it's another catchphrase, it's another thing that they want us to understand, that, and it doesn't really mean anything. There's a lot to unpack in those frameworks, things about power, systems, organisations, and individual practice. They're not, I think that the idea that, that treating people better or, improving access to services should be very simple, and it should be about, easy individual principles that people can do to change, and, I appreciate that, and I appreciate the frustration, but it doesn't happen. These aren't what we observe as to be intuitive behaviours by the systems, by the organisations and by the individuals. And so that we need these frameworks, I think, to be able to break it down, at a policy level, at an organisational level and at a practice level. I think there's a lot of value in the calls around, pieces like cultural safety is one that we see reported. There's a First Nations Aged Care Commissioner, Andrea Kelly, who recently released a report on access to aged care services for Aboriginal and Torres Strait Islander people. I did a lot of work with stolen generation survivors, and again, this access, this description of cultural safety came up a lot, and people probably say, well, what does that mean? And it's a whole range of things. It's about how you're treated at a service. It's about what the person who is providing the service knows about your history. It's about the language that is used in the environments that you enter into, you know, and you know, I think it is important.
Yeah, great. No, that's a really important perspective as well. Thanks for that. And Leonie, and thinking about how we can embed those kinds of critical frameworks into practice is really important. So thanks for that. I'm just going to move on to when circumstances where people are receiving care, and that whole concept of we've got language and then we've got behaviour. So there's a talking component, and then there's also the how our behaviours might surface in different settings, particularly in health settings. So I think for anyone in a health setting, there can be occasions where there are interventions we don't feel comfortable with, or they're personal, they can be personal or intimate, and this might be triggering, or it might lead to circumstances where we can't communicate what we're experiencing, and that can lead to behaviours that service providers might not always understand. Frank, I was just wanting to hand over to you for a moment to get a sense of your views on how older people might be treated if they don't behave in ways that care providers don't necessarily understand, where we can't always communicate using language, and how providers can effectively engage with older people and understand their experiences of care.
Yeah, I accept and support what's been said about the use of labels. They can limit the way we see a person. Once you put a label on a person, I think there's an inclination for that to be passed on from one carer to another, and the carer's not taking the person at face value as at how they meet them. So if somebody writes that the old person or the young person in an institution going back to decades earlier, if they write that the person is challenging or disruptive or unsettled or attention-seeking or withdrawn and so on, and then that gets passed on to the next person who's looking after that particular person, it can be extremely limiting. The judgment could be wrong in the first place, but what it doesn't do is actually describe the behaviour in terms of what actually happened. Maybe something was done to that person that made them disruptive. It was done without their consent. So we've been campaigning in the care leaver community for hearing the voices of the people who are concerned. If the records are being kept or written about people, they have a right to contribute to that. And if there are insulting or misleading descriptions of them or labels tagged to them, they have the right to challenge that. And they should never feel that people are making dossiers again about them and how they behave and how they are, because they're not just that one person in that one-dimensional sense. We are many types of people in our lives, and just being old or being disruptive or whatever is just one of those things. And there may be lots and lots of care leavers who don't want to be known as forgotten Australians or whatever. They just want to be taken as they are now. Thanks for
Great. That. Yeah. No, thank you, Frank. That's really important. Leonie, would you have anything that you would add around additional impacts and risks for First Nations peoples that arise with labelling in aged care settings?
Look, I think there's probably a few things in there to unpack. I think one of the pieces that's been highlighted for me, and this is around, sort of understanding trauma behaviours and those types of pieces, is often where those trauma symptoms may be misdiagnosed and understood as mental illnesses. So I think that's, one thing, or that it is, behaviours rather than symptoms, I guess, is the, if we are talking about, trauma, like responses and pieces like that. But, so there is a risk of misdiagnosing, poorly trained services, misusing those sort of categories. On the other side, I think there is that piece about that it is important to be able to collect information, keep information and store information and carry that information, especially where we might be talking about people who we were talking before about disclosure and the difficulty in sort of having to, repeatedly disclose and the, trauma that can recreate, so that I think there is a flip side to that where we need to think about how we can responsibly, collect information, that is given to us by survivors and respectfully use that to tailor their care and make sure their care needs are met.
Great, thank you. Sarah, any comments from you in relation to that point around labelling and language and behaviours?
I think labelling can be extraordinarily detrimental to anyone, particularly when you're in services and that gets carried with you. I think we need to reflect on our own practices and the things that may inadvertently be triggering the people that we're working with. Things like smells or what you're wearing or how you're presenting yourself can influence behaviour or trigger a response. So I think being really mindful of our own practices and how we're stepping into people's spaces to be as trauma informed as possible, and also acknowledging that language is different for everyone and making sure that we're tailoring how we speak and how we're engaging with who we're working with so that there is clear understanding, not so much jargon. Or I think that's super important, just to keep reflecting and keep challenging yourself every day that you're stepping into anyone else's space, is how is my influence influencing their behaviour, and how can I best respond in a way that is trauma informed and is responsive to that individual's needs.
Great, thank you, Sarah. Darcy, did you have any other additional comments that you'd like to also contribute to this point?
Oh, look, I think it's been covered really well. I really agree with Frank's point around the intersectionality. People's experiences are very diverse. They are not the abuse. That is something that happened to them. That's an important point to always reflect on for service providers, I think. I think the issue is with a label, it then predetermines a course of action, and that's not how it should be. I think what people seem to be asking for is an understanding broadly of their experiences and the flexibility to speak at an individual level to work out, well, what is meaningful for you? I think when we create a label, then it's this response that is predetermined. So I think it's just about understanding where people are coming from and where they're at. An example that comes to my mind is somebody may have been abused in a faith-based institution, for example, and the prospect of there being religious iconography in an aged care facility could be an incredibly triggering experience. But there are others that may identify living with spiritual harm, and actually re-engaging with a faith-based run institution and receiving care could be a real positive outcome. So it's such a spectrum. You can't predict how people will respond. It's about knowledge, understanding, and belief, and then tailoring responses based on the needs of the individual.
Great, thanks, Darcy. Look, continuing a little on the theme that Sarah started, I want to talk a little bit about how service providers can support older people to remain in their home. And we know that most people as they get older would want to remain where possible in their homes rather than moving into a residential setting. So Sarah, just going further on that point and reflecting on your research, when you've talked with older victims and survivors, what were some of the things that they've shared with you about this experience of in-home care versus moving into residential settings?
So the key findings from the Healthy Ageing study, we talked to quite a lot of individuals with who are old care leavers, and they're facing having to receive in-home support. So the vast majority of care leavers usually they don't think aged care is an option for them, and they want to remain in their home as long as possible. And unfortunately, a lot of participants explicitly stated that if they were forced to go into aged care, that they would prefer to end their lives, as they still have a very real fear of reinstitutionalisation and re-traumatisation in aged care settings, which are the key components of aged care support are actually potentially triggering, including lack of flexibility, lack of autonomy, existing power imbalances between residents and staff, the lack of privacy, enclosed spaces, communal living, receiving personal care and medical treatments, as well as physical features such as like corridors, the smell of disinfectants, dark panelling, names of institutions carried over to other aged care facilities, such as faith-based. They may be exposed to other triggers such as certain holidays, foods, episodes of incontinence, visible religious symbols, and also there's a lot of workforce issues which provide challenges to implementing trauma-informed care, such as staff turnover, skill disparity, cultural language barriers, difficulty meeting complex behavioural needs with limited resources. Lack of family support is an additional barrier to navigating aged care services, as well as the cost associated. Lack of services or information about services, and lack of transport. So preferences for care that prioritises autonomy and does not force them to divulge or repeat their story unnecessarily has been highlighted as a big need as well. So there's quite a few compounding factors there that influence the perception of aged care. But I think it's quite clear that we need to really be adding resources to ensure that care leavers are able to remain in their home as best supported as we possibly can. Yes.
Great. And thanks for that, Sarah. Any comment from you, Frank, in relation to this point? I know this is something that we've heard you talk about.
Absolutely. Yeah, absolutely. I agree. I don't know whether this is happening to other people, but I've been bombarded in the last couple of weeks with offers of better services from a whole variety of agencies. And it's quite bewildering. I'm a reasonably educated person. I understand what people are on about, but I think a lot of care leavers getting this information would be absolutely confused and bamboozled. They want information of a different kind from that which is being offered by these providers. They want to know what services are available, who runs them, and what will it cost me, particularly that. Can I afford it? Is there a danger that I'm going to lose my independence? What if I don't like the helpers? Can I opt out? Have I got any rights in that matter? These are simple questions that people ask, and they don't get the answers readily through the kind of advertisements that are taking place on Facebook, for example, on other social media outlets. I just find the total lack of ability to get inside the head of the aged care person to understand what they would want to know. It's clear what they want to know, the sorts of questions I just enumerated, but I find it really hard to get clear answers of that type from the information that I see.
Yeah, great. Thanks for that. Any comments before I move on to the next subject or our final sort of area, Leonie or Darcy?
Sorry, you go, Darcy.
Leonie, yeah.
No, please, Leonie.
So I just think that, acknowledge that Sarah and Frank have covered off some of those points really beautifully. I think all of those issues around, the smell, the putting people back in institutions, where you're re-triggered, that that autonomy and that sense of control of your environment, are so critical to that experience of residential aged care. I will just say, a little bit to the point around the, you know, and the other thing I think that was touched on there as well by both was about the relationships with the providers or, you know, the workers in these settings, and often there might be a high level of turnover, and, you know, the importance of having this relationship and trust in those relationships. I think that's something that we see quite commonly. I think the other thing that I just did want to throw in there is about this broader cultural and intergenerational element for us, and you know, I don't think this is just isolated to Aboriginal and Torres Strait Islander children, but, you know, we talk a lot about the effects, the intergenerational effects for someone who was removed, you know, how it's sort of manifested in parenting skills, and that child may carry, you know, trauma, but, you know, also knowing the experiences, so that having to put someone back into, you know, a residential setting is also quite damaging. And I think that we see a lot about the president, you know, the preference for in-home care rather than residential aged care, but I know that that's not always possible. But I think that I do want to emphasise the importance of connection for a lot of our survivors. There might have been removal from country and culture and family that they've had to rebuild. That also that it's what we've seen with some of our areas. Kinchela Boys Home is an example where they talk a lot about the ability to come back together as these boys in these institutions who were often, you know, quite divided because of the way that the abuse occurred, and, you know, had these quite, you know, hard lives afterwards, you know, where they were sort of in and out of institutions, and had all this thing about the power of them being able to come back and reunite, and, you know, collectively they were able to, you know, begin to tell these stories of disclosure and heal. So making sure that we have aged care services that can reinforce those connections, I think, is not just important for the survivor or the person who's entering aged care, sorry, but also the for us as a community, you know, for us as the carers, descendants, you know, like our old people and our elders is such an important part of our culture and our cultural continuity, you know, to have to put people in, you know, a care service that they don't want to be in, that they're rejecting, is sort of very painful, but it's also a big loss of knowledge, cultural continuity and social connection, you know, more broadly for communities that are trying to heal.
Yeah, thanks, Leonie. Darcy.
Yeah, look, I would just quickly say, I think, you know, to Frank's point, I agree. I think that the system is more interested now in supporting people to stay at home for longer. And I don't think that many people that are eligible for aged care services feel that. So I think that's something that we need to be able to articulate. And also to Sarah's point, look, I would echo what she said. It is a common thing for forgotten Australians at Access Lotus Place to say, I would rather commit suicide than to end my days being vulnerable in an institution the same way that I started them. I think one thing that we have learned in our conversations, one of the programs that operates out of microprojects is one of the PHN funded Care Finder programs, that we need to be having a conversation with people, which is, you know, that might be a position, but there are many people that, due to circumstances beyond their control, end up in an aged care facility. That might be because of dementia, or it may be because somebody has a fall. So how can we have a conversation about what you need right now, and if circumstances were ever to change in the future and you didn't have the same agency, what would you need in order for that to be a safe place for you? And I think that's a difficult but a really important conversation to be having with people.
Yeah, great. Thanks, Darcy. Look, I'm really mindful, everyone, that we've only got 5 minutes left. We started a little late, so I know there's probably lots of questions, and we do have responses that we can get back to everybody. But I'd like to move into wrapping up and to just hear from each of the panelists in, you know, your 60 seconds or less. And maybe just integrate, Leonie touched a little on healing, and maybe integrate that into your sort of wrap-up comments. We're often talking about practical care in the context of aged care services and enabling quality of life, but is there any space in this discussion for healing and recovery? And yeah, we've got about 60 seconds each. Is there anyone who'd like to kick off on that? Perhaps Leonie.
Sorry, I feel like I've touched on this a fair bit, but I would just like to re-emphasise the importance of social, emotional well-being. You know, it's a continuing thing. It continues for people as they access their aged care system, and it's so important that we, you know, think about how services can encompass those elements around, you know, cultural practice, social connection, music, cultural, you know, language, and those types of things that are important for people to practice. The other thing that I would just like to point towards in the healing, and it's been touched on a fair bit here, is this responsibility of these institutions who were involved in the historical abuses, who are still involved in the delivery of these types of services in these homes, to really step up and take responsibility and action around their part. I think that's a big part of healing for survivors and people accessing aged care services.
Thanks, Leonie. Frank.
Yeah, I guess for me, just a key point is that I want to continue on having the best quality of life that I possibly can in my final stages of life. Every day's got to be a good day for me, and if care providers thought of it in those terms, I think it might make a difference. I don't want to be treated as if I'm frail and old and sick or something of that sort. There are lots of things in my life that I want to keep doing, and I would look forward to help from carers who can actually enable that to happen. Every day's got to be a good day for me, and if the care system can help with that, terrific. I don't want them necessarily to help me with the trauma of child abuse. I want them to help me enjoy my life.
Thanks, Frank. Sarah.
Many older care leavers that I've interviewed expressed feeling that they experienced practices that were inherently paternalistic, much like what Frank was saying, is like you being viewed as you're old or you're frail or you don't have the capacity anymore to make your own decisions. And I think that is something that we really need to be mindful of, and inherently we need to view as a person having consent and capacity to make their own decisions. They have choice and control, and including dignity of risk. A lot of older care leavers expressed control or coercion around either making their own decisions on smoking cigarettes or drinking. These are completely legal things that they have the right to do. We need to respect personal autonomy and choice. As older care leavers, as anyone ages, like you are an adult and you should always presume to have capacity unless otherwise legally removed. And I think we just need to be really mindful of paternalistic practices.
Thanks, Sarah. And Darcy.
Thanks. So I'm trying to think of some really practical things, I suppose. But look, survivors need quality care. They need respect for their childhood experiences of abuse and the lifelong impact that comes with trauma from that abuse. So I think as people experience the aging process, they're also experiencing strong emotions about the experiences of abuse, and that's something that's reflected on regularly. I think it's really important that people in aged care know that when they hear these stories, that they don't think that it's being made up, that they're actually believing people. They don't think it's down to memory loss, but it's in fact something that has been publicly acknowledged through many reports, inquiries, and there is so much evidence to support what it is that people are saying. People need to have the confidence to feel that they won't be exploited sexually by staff. I think that's something that we don't talk about enough, and that physical restraint won't be used to manage reactions, these trauma responses. I think importantly, if people report any form of abuse, that they will be believed. And people may also struggle with a lack of choice of providers. So I don't think there's enough opportunity to have some agency over that. And often many people are left with no options regarding providers, but are often faith-based providers. So I think really practical things that comes from a place of understanding and just working with people at an individual level and not having broad brush approaches to supporting people.
Great. Thanks for those final practical considerations, Darcy. It's been great to have you all, Leonie, Frank, Sarah and Darcy. Thanks so much for joining us today, and thanks everyone who's been tuned in, and also for your questions, which we haven't had an opportunity to address at this point, but we will certainly be following up post or after the webinar. As I said at the outset, it would be great if you could fill in the survey so that we can work to improving these each time we do them. And we will continue to provide any relevant news about the National Centre through our newsletter and our socials. So if you haven't subscribed to our newsletter, please do. And on that note, I'm going to sign us all off and close the webinar for today. Thanks so much, everybody, and have a great rest of your day.
Thanks, everybody.
Thank you, Janine. Thank you.
Thank you.